Hello, I am going to go over Chapter 41, Nursing Care of the Child with an Alteration in Perfusion Cardiovascular Disorder with you. Your Ricci, Carman, Maternity and Pediatric Nursing 5th edition book. So here are your learning objectives. Um, when we complete this lecture, you should be able to compare the anatomic and physiologic differences of the cardiovascular system in infants and children versus adults. Describe nursing care related to common laboratory and diagnostic tests using the medical diagnosis of pediatric cardiovascular conditions. Distinguish cardiovascular disorders common in infants, children, and adolescents. Identify appropriate nursing assessments and interventions related to medications and treatments for pediatric cardiovascular disorders. Develop an individualized nursing care plan or concept map for the child with a cardiovascular disorder. Describe the psychosocial impact of chronic cardiovascular disorders on children. Devise a nutrition plan for the child with cardiovascular disease and develop child family teaching plans for the child with cardiovascular disorder. So we always want to begin with looking at cardiovascular system development, just going back to our anatomy and physiology and what happens during conception and as a fetus grows and then when a baby's born. So just as a reminder that around post-conceptual day 17, the fetal heart rate is present. And weeks 2 through 8, the baby's heart chambers and arteries are formed. Oxygenation of the fetus occurs via the placenta because the lungs, they do get perfusion, but they don't perform oxygenation and ventilation due to being in a fluid-filled environment. The placenta does that for the fetus. The foramen ovale, the opening between the atria, allows blood flow from the right to the left atrium, and the ductus arteriosus allows blood flow between the pulmonary artery and the aorta, which causes that shunting of blood away from the pulmonary circulation. So this is figure 41.1 in your textbook on page 1351. And it just gives you a good picture of A, fetal circulation, and B, what happens when a baby is born and newborn circulation occurs. So that change from fetal circulation to newborn circulation. So this is something that I mentioned way back in chapter 10 that you would need to know for pediatrics. So I'm not going to spend a whole lot of time on this. But remember that when a baby is born, there are several different things that are happening that help the pressures within the lungs and within the heart to change, including clamping off the cord and cutting it. The baby's first cry with inhaling and breathing. And so that helps for your foramen ovale, your ductus arteriosus, and that ductus venosus to start closing off. And then we have our arteries carrying our blood around that's been from the aorta that has been oxygenated to the rest of the body, and our veins bringing back the deoxygenated blood from the inferior and superior vena cava back into the heart to go to the lungs. So, what cardiovascular changes occur in childhood? Well, we know that in utero, the fetal heart rate ranges from 110 to 160 beats per minute as a heart rate baseline. So it's safe to say that our infant's heart rate is going to remain faster. So your book talks about 90 to 160 beats per minute in this chapter. And then as the child ages, that heart rate decreases. Now, on the flip side, the blood pressure in the infant is much lower. So it's going to be approximately around 80 systolic over 55 diastolic millimeters of mercury. So it'll be much lower, but then it will increase as the child ages. So by the time the child reaches adolescence, the heart rate and the blood pressure should reach adult levels. Now, within this chapter, we have to discuss the difference between congenital heart diseases or CHD versus acquired cardiovascular diseases. So, congenital heart diseases are structural anomalies that are present at birth. They account for the largest portion of all birth defects, and typically you will see signs and symptoms of these structural anomalies that are present at birth shortly after birth. Now, acquired cardiovascular disease are any disorders that occur after birth. So, heart failure is going to be one of the main acquired cardiovascular diseases. And you can actually get heart failure from a congenital heart disease. And so that's going to be your most common reason for admission for these kiddos. And of course, we have to always sit and think that acquired cardiovascular disorders, they develop from a wide range of causes or could obviously be a complication or a long-term effect from CHD. So, what are some risk factors for cardiovascular disorders in childhood? For congenital, we have congenital malformations, different genetic syndromes like trisomy 21 or DeGeorge syndrome, Turner syndrome, trisomy 13 and 18, Prader-Willi syndrome, Kruger-Schott syndrome, Williams syndrome. There could be a family history of it. It could be because of maternal drug or alcohol exposure, or even just simply because of prematurity. With your acquired cardiovascular disorders, this could occur due to different infections like rheumatic fever, Kawasaki's disease, endocarditis, obesity, diabetes, drug or alcohol exposure, hypertension, side effect of chemotherapy, other disease processes like connective tissue disorders, autoimmune or endocrine diseases, organ transplant, and even hyperlipidemia. So when we look at congenital heart diseases, those are based on the hemodynamic characteristics. So we look at disorders with decreased pulmonary blood flow, disorders with increased pulmonary blood flow, obstructive disorders, and mixed disorders. So disorders with decreased pulmonary blood flow, those are going to be your cyanotic babies, your babies with tetralogy of Fallot, your tricuspid atresia kiddos. Disorders with increased pulmonary blood flow. These kiddos are not necessarily going to have the cyanosis, but they may have other signs and symptoms. That's your patent ductus arteriosus or PDA, atrial septal defect, ASD, ventricular septal defect, VSD. Now, with the obstructive disorders, we have coarctation of the aorta, aortic stenosis, and pulmonary stenosis. And our mixed disorders, we have transposition of the great vessels or TGV, total anomalous pulmonary venous return or TAPVR, truncus arteriosus, and hypoplastic left heart syndrome. So I've included the different figures and page numbers from your book for each of these so that you can go back and review them all. I'm going to go over just a handful, though, right now with you, starting with our disorders with our decreased blood flow. So we have tetralogy of Fallot, figure 41.2. And that one is composed of 4 heart defects, and you need to understand that and know that. The 4 heart defects include pulmonary stenosis, VSD, overriding aorta, and right ventricular hypertrophy. Tetralogy of Fallot is usually diagnosed during the first weeks of life due to the presence of a murmur and or cyanosis. Surgical intervention is usually required during the first year of life. Now, tricuspid atresia. Tricuspid atresia is figure 41.3 in your book. And this is the failed development of the valve between the right atrium and the right ventricle, causing no opening to allow blood flow between them, and subsequently through the pulmonary artery to the lungs. So you get deoxygenated blood to pass through the patent foramen ovale to the left atrium, mixing with the oxygenated blood. The mixed blood travels to the lungs through a PDA, making the baby have inadequately oxygenated blood. Now, let's look at some disorders of the heart that have increased pulmonary flow. So atrial septal defect is a hole in the wall or the septum that divides the right atrium from the left atrium. So you have blood flowing from the opening from the left atrium to the right atrium due to the pressure differences. That shunting increases the blood volume entering the right atrium, causing increased blood flow to the lungs. If left untreated, the defect can cause problems like pulmonary hypertension, heart failure, atrial arrhythmias, and even stroke. Most children with ASDs are asymptomatic. However, if a very large defect is present, it can cause increased blood flow, leading to that heart failure, which results in shortness of breath, easy fatigability, and poor growth. Now, let's talk a moment about ventricular septal defect. VSD is an opening between the right and the left ventricular chambers of the heart, and this is one of the most common congenital heart defects. So the opening varies in size. It could be as small as a pinhole to a complete opening between the ventricles so that the right and left sides are as one. Small VSDs may not have any symptoms at all. but larger or complete openings will definitely show signs and symptoms. Initially, these babies may not have any signs and symptoms at birth because of the left to right shunting, due with being minimal due to the high pulmonary resistance right after birth. However, commonly revealed signs of heart failure arise around 4 to 8 weeks of age. So you would want to note a history of the baby tiring easily, particularly with exertion, feeding, difficulty thriving, color change or diaphoresis with feeding, frequent pulmonary infection, shortness of breath, possibly edema, mild tachypnea, characteristic holosystolic harsh murmur along with the left sternal border, possible adventitious lung sounds, and possible palpation of a thrill at the chest. And then we have figure 41.8, which is our coarctation of the aorta. And so this is a narrowing of the aorta, which is that major blood vessel carrying highly oxygenated blood from the left ventricle of the heart to the rest of the body. It most often occurs near the ductus arteriosus. It can be preductal, which is between the subclavian artery and the ductus arteriosus, or postductal, which is after the ductus arteriosus. Blood flow is impeded. It causes pressure to increase in the area proximal to the defect and to decrease in the area distal to it. So it causes the blood pressure increased in the heart and upper portions of the body with decreased blood pressure in the lower portions of the body. So due to the elevation in blood pressure, the child is at risk for aortic rupture, aortic aneurysm, and CVA. Extent of the symptoms depends on the severity of the coarctation. Assessment findings may reveal full bounding pulses in the upper extremities with weak or absent pulses in the lower extremities. These babies may have problems with irritability and frequent epistaxis. The blood pressure in the upper extremities may be 20 millimeters of mercury or higher than that of the lower extremities. A soft or moderately loud systolic murmur auscultated is most often at the base of the heart, on the back, or in the left axilla is where you would hear it probably the best. Let's have a little quick knowledge check. What are some findings on a newborn assessment that would indicate to you that the neonate has a congenital heart defect? A good idea just to pause it for a moment and think about it, taking you way back. So assessment findings may include blood pressure discrepancy between the extremities, cyanosis that persists beyond the initial transitional phase after birth, episodes of hypoxia, especially when it persists beyond the initial transitional phase after birth, heart murmur that persists beyond the initial days following birth, lethargy, poor feeding habits or consistent decline in feeding habits, pulse abnormalities. Depending on the defect, the pulses could be bounding, weak, or absent. So those are just some assessment findings that you could potentially find in the newborn population with a congenital heart defect. So if you guessed any of those, great job. Now it's time to pivot and talk a little bit more about acquired cardiovascular disorders. And again, these can be due to infections, obesity, diabetes, drug or alcohol exposure, hypertension, chemotherapy, other diseases, organ transplant, or hyperlipidemia. Signs of a cardiac disorder would include cyanosis, irregular heart rate, edema, clubbing of the fingertips, fever, retractions or increased work of breathing, prominence of that precordial chest wall, visible engorged or abnormal pulsations, abdominal distension. Risk factors for cardiovascular disorders include a family history of heart disease or congenital heart disease. So you would want to investigate the history further if a heart disease occurred in a first-degree relative, okay? And of course, sudden death in a young family member that's contributed to a heart problem, family history of hyperlipidemia, diabetes. We also want to look at history of the present illness. When did the symptoms start and how did they progress? What treatments and medications were used at home? What is that baby or child's activity level compared to before or to their peers? Does this child have a history of orthopnea, dyspnea, easy fatigability, growth delays or failure to thrive, squatting, edema, dizziness, frequent pneumonia, poor feeding, fatigue, lethargy, vomiting, diaphoresis, motor delays, cyanosis, tachypnea? With their past health history, we would want to know any problems occurring after birth. Do they have any congenital malformations? What is their birth history? Did they have any NICU stays? Do they have a history of frequent infections? If so, what kind? Do they have any chromosomal abnormalities? Do they have a history of prematurity? What about autoimmune disorders? Their use of medications such as corticosteroid use. And what questions could you ask when taking a child's health history? So this is table 41.1 in your book. And so I like this table because it gives you the question and you just look straight over from left to right. And it gives you also the information that that question will provide you. So what types and amounts of medication has a child received and what are they used for? Who prescribed them? Were they effective? Did they experience any adverse effects? To whom does the child go for medical evaluations? How often? Were the visits regular, or were they for regular health checkups or for situational problems like sick visits? Were there any previous hospitalizations and what for? Asking about growth delay, any problems with activity and coordination? Does the child's skin color change when crying? If it does, what color is it? Does the child stop frequently during play to sit or squat? Does the child have feeding difficulties and tire easily or sleep excessively? Does the child frequently develop strep throat? This is something that I thought was a good thing to include is characteristics of heart murmurs. So we want to know where at on the chest it's best heard and does it radiate anywhere else? Where does the heart murmur occur in relation to the heart cycle and the duration? What's the quality? Is it harsh, musical, or rough, like a high, medium, or a low pitch? Is there a variation in sound with the position of the client, whether they're sitting, lying, or standing? And then, of course, looking at the intensity or grading of the heart murmurs, grade 1 is soft and hard to hear. Grade 2 is soft and easily heard. Grade 3, loud without a thrill. Grade 4 is loud with a precordial thrill. Grade 5 is loud, audible with a stethoscope. Grade 6 is very loud, audible with the stethoscope or with the naked ear. All right, knowledge check. Jeremy is a 2-year-old child with VSD who is scheduled for a cardiac catheterization tomorrow. What information will you be sure to include when providing pre-procedure education to his parents? Now would be a good time to pause. So possible education information for Jeremy's parents may include teaching them and Jeremy, if it's age appropriate, about all aspects of the procedure in order to decrease their anxiety. Include information about what the procedure involves. How long is it going to take? Any special instructions from the provider that they're going to need to know. Explain the use of intravenous fluid therapy, sedation, and if ordered, anesthesia. Tell the families to withhold food and fluids for 4 to 6 hours before the procedure as ordered. However, the parent should administer prescribed medications with a sip of water. Teach the child and family what to expect after the procedure is completed. Inform the parents of the possible complications that could occur, like bleeding, low-grade fever, loss of pulse in the extremity used for the catheterization procedure, and the development of an arrhythmia or abnormal heart rhythm. Inform the parents that the child will have a dressing over the catheter site and that the child will need to keep the leg straight for several hours after the procedure. Teach the child and parent that frequent monitoring will be required after the procedure. And you need to discuss the post-procedure discharge education with the parents and the child if age appropriate prior to being discharged home. So look at Teaching Guidelines 41.1 in your book. Areas to address include site care, signs and symptoms of complications, especially within 24 hours after catheterization, like fever, bleeding, or bruising at the site, changes in color, temperature, and sensation in the extremity used. Also discuss diet and activity level with them. So I wanted to include just a couple of little pictures, and these do not come from your book. The top 2 pictures come from Oregon Health and Science University, and it's just showing you a cardiac cath where they will go in the femoral vein for an infant or a child, and they will feed that catheter up into the heart. And then, of course, the bottom picture, you can kind of see the setup and how things are kind of going on. So I just wanted to include that so you can pause and just take a look at your leisure. Now, post-cardiac catheterization, as a nurse, we have to do some assessments when these kiddos come back to be placed in our care. So we want to monitor for complications of bleeding, arrhythmia, hematoma, and thrombus formation. We want to evaluate the vital signs, including pulse oximetry, cardiac rhythm, neurovascular status of lower extremities, including color and temperature. And we want to evaluate the pressure dressing over the site. So I included a take note for you on here. As a reminder, this comes straight from your book. that if bleeding occurs after cardiac catheterization, you need to apply pressure 1 inch above the site to create pressure over that vessel to reduce the blood flow to that area. It's kind of like putting almost like you're just putting a tourniquet there, but you're using your hand and putting that pressure 1 inch above it to stop that blood flow. And so the pictures you are seeing at the top, you are seeing two different ages of children who are getting prepped for cardiac catheterization. And then the bottom picture is a child post cardiac catheterization. And I want you to pay special attention to our lower extremities. This child had the cardiac cath in their left femoral, and that you can see the color difference in that leg. So they had a thrombus formation that they've had to get treated for. And of course, you can see this little one's had some previous cardiac surgery and things like that too. So that was something that I thought was kind of neat to show you, the distinct difference in the color between the limbs when there's a problem that has occurred. So teaching guidelines for providing care after a cardiac catheterization, 41.1, this comes straight from your book as well. You're going to want to teach that the pressure dressing needs to be changed on the day after the procedure, and they're going to apply a dry sterile dressing and new dry clean adhesive bandage for the next several days. They need to keep the dressing dry, cover it with plastic if it could get wet or soiled. When they do change that dressing, they need to be looking at that area, that insertion site area, for any redness, irritation, swelling, drainage, bleeding. And if they see any of those, they need to report it to the healthcare provider. They need to be checking the temperature, color, sensation, and the pulses on the child's extremities and comparing one limb to the other, upper and lower, and report any changes to the healthcare provider. They can resume the child's usual diet after the procedure and report any nausea or vomiting. They need to check the child's temperature at least once a day for at least 3 days after the procedure and report any temperature elevation of 100.4, 100.4 degrees Fahrenheit or greater. Avoid giving the child a tub bath for approximately 3 days after the procedure. Use sponge baths or showers instead, while keeping the area covered well with plastic. Discourage strenuous activity or activity for approximately 3 days post-procedure. Watch for changes in the child's appearance, like skin color, reports of their heart fluttering or skipping a beat, fever, trouble breathing. You may give acetaminophen or ibuprofen for complaints of pain. Schedule a follow-up appointment with the healthcare provider in the time specified. So these are all teaching guidelines for providing care after cardiac catheterization. This is what we should be teaching the parents. And this teaching should start before the surgery and be reiterated after the surgery. Now, let's flip over to heart failure. This is figure 41.15 in your book, and it's the pathophysiology of heart failure. So with heart failure, you've got neurohormonal factors, systolic dysfunction, and diastolic dysfunction. And these 3 different factors contribute to heart failure and the different signs and symptoms. So with neurohormonal factors, you have the sympathetic nervous system stimulation, which is going to cause an enhanced peripheral vascular resistance, an increased beta adrenergic activity, improved contractility and cholinergic stimulation. It also, we have to look at that renin secretion, angiotensin 1 to angiotensin 2 activation system. So there will be an increased resorption of sodium and water in the renal tubules, an increased blood volume. The adrenal glands with aldosterone will cause increase in sodium retention. And of course, the pituitary gland's antidiuretic hormone will increase water retention. So the client will have, because of this, will have tachycardia, pallor due to vasoconstriction, low urine output, sweating, increased blood pressure, edema, and weight gain. With systolic dysfunction, we have increased preload that leads to increased stroke volume during the contraction. The cardiac muscle stretches to accept that increased intravascular volume. We have increased left-sided filling pressure and increased myocardial oxygen demand, pulmonary congestion, interstitial pulmonary, bronchiolar, and alveolar edema, and impaired gas exchange. So this causes the body to show symptoms of increased work of breathing, tachypnea, retractions, and grunting. Clients may have wheezing, coughing, and rales. You may see dyspnea on exertion and feeding difficulties. With diastolic dysfunction, you'll have increased right-sided filling pressure, hepatic venous congestion, systemic venous congestion. There'll be pumping against the increased resistance, and there'll be increased myocardial oxygen demand. So this is going to lead to hepatomegaly. In older children, you'll see jugular venous distension or JVD, and it's common to see periorbital edema with these little ones. So heart failure is a consequence of many congenital and acquired cardiovascular disorders. We went over the pathophysiology already, but nursing management. So it's important for us as nurses to promote oxygenation, to support their cardiac function, to provide adequate nutrition, and promote rest. And so you're like, well, how do we do that? Well, first of all, we want to assess airway impatency and suction as needed. You can position the child in a Fowler or semi-Fowler position to help facilitate lung expansion. We're monitoring vital signs, and especially those heart and respiratory rates. We're looking at that child's color and monitoring their oxygen saturation levels closely. And that will help guide our oxygen administration as needed. We're looking for tachypnea and other signs of respiratory distress. We're auscultating the lungs for adventitious sounds. When we do provide supplemental oxygen, we will provide warm, humidified oxygen for the child. And we always need to remember to anticipate the potential need for assisted ventilation if the child has difficulty maintaining their airway or deterioration of their status occurs. We also need to remember that children with disorders like tetralogy of Fallot and heart failure are prone to having hyper, H-Y-P-E-R, hypercyanotic spells. And we often hear that called TET spells, T-E-T, TET spells. So hypercyanotic spells usually will occur when the child is crying or feeding and or overexerting themselves. And what happens in an older child, of course, they'll turn blue, number one. And number two, your older child will squat. Now, your baby who can't do that is not going to be able to do that. So squatting helps to put more force there to try to breathe better. So how do we relieve that? Well, we'll talk about that in just a little bit. Promoting adequate nutrition is important too, because whether it's orally, intraorally, or parenterally, we have to foster their growth and development and reduce the risk of infection. And so, depending on what's going on with the child, will depend on what nutritional feeding method they will get. So, for instance, let's say we have an infant with a congenital heart disorder. In order to make, in their bottle feeding, in order to make feeding less of a chore and make it easier for the child to do and to decrease their work of feeding, we can alter the nipple or get a fast flow nipple so that it makes it easier for the child to eat. For an older child, offering small, frequent feedings to reduce the amount of energy required is important. Preventing infection is important. Proper hand hygiene, number one. Hand hygiene is huge. The next is oral hygiene. These little ones need to be maintaining proper dental care. They need to receive prophylaxis for infective endocarditis as needed. If they are 24 months or younger and they are going to have to undergo a heart transplantation during RSV season, then they will need to get the vaccination during that time. And of course, we can do a lot of things to promote rest, clustering of care to promote rest, and things like that. And then assist with coping for the child and the family. It can be very overwhelming to deal with disorders and disease processes of various kinds. And so getting all the tests done, diagnostic testing, and getting, just lots of having to go back and forth to lots of doctor's appointments and different types of doctors, because you can't just go to one and they do everything. Going to the hospital to have surgery. There's so much involved. So, ensuring that parents and the child are coping and in providing education on the healthy therapeutic ways of coping is important as well. So we're going to pivot over now to infective endocarditis. This is a bacterial infection of the endothelial surfaces of the heart. The valves is usually the most common. Then chamber walls and septum can also be infected and have problems as well. There's an increased risk with prosthetic valves, and this absolutely requires antibiotic treatment. Acute rheumatic fever. So acute rheumatic fever is a delayed sequela of group A streptococcal pharyngeal infection. And you'll hear acute rheumatic fever called ARF. So you typically see this more often in our school-age children between ages 5 and 15. And you usually see this develop about 2 to 4 weeks after the initial streptococcal infection. And so the current understanding of what's going on with the body is that the child is developing an antibody response to the surface proteins of the bacteria. So those antibodies cross-react with the antigens in the cardiac muscle and neuronal and synovial tissues, causing carditis, arthritis, and chorea, which is involuntary random jerking movements. So it affects the joints, central nervous system, skin, subcutaneous tissue. It can cause chronic progressive damage to the heart and valves. Most episodes of acute rheumatic fever will resolve, but it may recur with subsequent streptococcal infections. So diagnosis of ARF is based on the modified Jones criteria, and you're going to want to know this. In order to be diagnosed with acute rheumatic fever, the child needs to have the presence of at least 2 major criteria or 1 major plus 2 minor criteria. So under major criteria, it's carditis, migratory polyarthritis, subcutaneous nodules, erythema marginatum, Sydenham chorea. And remember I said chorea was those jerky body movements. They're involuntary random jerky movements in the body. Minor criteria is polyarthralgia, elevated ESR or CRP, and prolonged PR interval unless carditis is a major criterion. So if carditis is the major criterion, it has to be 2 of the others. So it can be polyarthralgia and an elevated ESR or polyarthralgia and an elevated CRP, if that makes sense. So we want to, as a nurse, get a description of the present illness and the chief complaint, noting any fever and joint pain. Also, did they have a documented strep infection or sore throat within the past 2 to 3 weeks? To just see, their risk factors for acute rheumatic fever. We want to observe the child for Sydenham chorea, and that's usually the movement disorder. It occurs in that face and upper extremities. We want to look at the skin for evidence of that classic rash, that erythema marginatum. It's a maculopapular red rash with central clearing and elevated edges. We want to auscultate the child's heart and note if there's a murmur. Palpate the surface of the wrists, elbows, and knees for firm, painless subcutaneous nodules. And then get an ECG and note if there's any prolonged PR intervals. So when we care for a child with acute rheumatic fever, our focus is ensuring compliance with the completing the course of antibiotics and for the acute course, as well as any prophylaxis following initial recovery. The child is going to be frustrated, especially if they have those chorea symptoms. So provide support for dealing with any of those abnormal movements. Let them know that that will eventually disappear. But it could last for several months, unfortunately. Sometimes kids may need a neuroepileptic medication like haloperidol to manage that chorea. We also need to administer corticosteroids or non-steroidal anti-inflammatory agents for control of their joint pain and swelling. Cardiomyopathy. So we need to look at the risk factors, congenital heart defect, genetic disorders, inflammatory or infectious processes, post-transplant or post-operatively after cardiac surgery, hypertension, and then we have our two muscular dystrophies listed. Most commonly, we don't necessarily know the reason, so it's considered idiopathic. But at any rate, the child may present as heart failure or cardiac arrest. So with cardiomyopathy, the myocardium just can't contract properly. So you have three types: restrictive, dilated, and hypertrophic. Restrictive cardiomyopathy is rare in children, and it's a result of atrial relaxation. Dilated cardiomyopathy is the most common type in childhood, and it's the one that presents as heart failure because of the ventricular dilation and decreased contractility. And there may be some familial tendency towards dilated cardiomyopathy as well. Hypertrophic cardiomyopathy is more common in adolescence and results in the hypertrophy of the heart muscle, particularly in that left ventricle, and that affects that heart's ability to feel. So around 2/3 of the cases are familial. Some are inherited in an autosomal dominant fashion, but there's no cure for cardiomyopathy. Whatever damage that's done is there. The heart muscle function cannot be restored. So we have to provide therapeutic management and direct that towards improving heart function and blood pressure. These kids may need mechanical ventilation and vasoactive medications. ACE inhibitors, beta blockers, or calcium channel blockers may be used. Some kids may need pacemakers or even surgery. Heart transplantation may also be an option for children whom medical management is unsuccessful, and that would be the only viable long-term treatment option. When we get a history on these kiddos, not only do we want to look for any of the risk factors, but we also want to look for a history of respiratory distress, fatigue, poor growth, chest pain, dizziness, syncope. We want to look for extremity edema and abdominal distension, note any increased work of breathing. When we auscultate the heart, we want to note tachycardia and any irregular rhythms. We want to get an ECG to evaluate the heart rhythm. And then, of course, getting a chest radiography can reveal cardiomegaly or congested lungs. These kids, as far as nursing management's concerned, they require intensive care initially. So they're going to be monitored closely for blood clots and arrhythmias that could lead to cardiac arrest. Of course, we're going to be monitoring for heart failure and providing any interventions related to that. monitoring closely for the responses to any of the medication therapies that they're prescribed, helping support the child to choose activities that fit with their restrictions, and lots of emotional support to the child and family. Again, it's stressful when they begin to understand the severity of the illness. Kawasaki disease. So Kawasaki disease is an acute systemic vasculitis that occurs in children between 6 months to 5 years of age, usually. It's the leading cause of acquired heart disease among children in the United States, and it affects all ethnic groups, but more frequently in those of Asian or Pacific descent. It is self-limiting, but can cause cardiovascular complications like coronary artery aneurysm and cardiomyopathy. So it's something we shouldn't just take lightly. It is managed by focusing on reducing the inflammation in the walls of the coronary arteries and preventing coronary thrombosis. So these kids may have signs and symptoms of a high fever for about 5 days that's unresponsive to antibiotics, chills, headache, malaise, extreme irritability, distinctive rashes like a strawberry tongue or palmar erythema, desquamation or peeling of the skin of the perineum, fingers and toes, vomiting, diarrhea, abdominal and joint pain. Now, chronic management of children developing aneurysms during the initial phase is directed towards preventing any kind of myocardial ischemia. But in the acute phase, we give high-dose aspirin in 4 divided doses daily and a single infusion of intravenous immunoglobulin or IVIG. Okay? So these kids will have long-term monitoring of their coronary arteries. Now, while the pathophysiology behind Kawasaki disease is roughly still unknown, current thoughts are along the lines of some infectious organism causing disease in genetically susceptible people, because it appears to be an autoimmune response mediated by cytokine-induced endothelial cell surface antigens leading to vasculitis in the medium-sized arteries, like your coronary arteries. So that completely impairs the structure of the vessel wall and causes all these problems. Now, some kids may never develop coronary artery changes, while others get your aneurysm or other sequelae. Now, how do we help these kids? So other than providing the aspirin and IVIG, we want to focus on monitoring their cardiac status, promoting comfort, providing family education, and child education. Now, let's pivot and focus a little on the care and education aspect of the child with a cardiovascular disorder. So diagnostic tests for cardiovascular disorders, we have pulse oximetry, ECG and Holter monitoring, echocardiogram, chest radiograph, exercise stress testing, laboratory testing, getting blood tests, arteriogram and cardiac catheterization. And then you have in your book, Common Lab and Diagnostic Tests 41.1. So it goes through several different tests. It gives you a good explanation, indications, and nursing implications. So this is one I would go over as well. And you can see it goes through several different things. Now, common medical treatments. 41.1 in your book. So obviously oxygen, chest physiotherapy and postural drainage may need to be performed. Chest tube placement and pacing. And this comes straight from your book on page 1352. And again, it gives you the treatment, explanation, indications, and the nursing implications. So I really like that the chart breaks it down like that for you. Now, 41.2, common surgical procedures. It lists a whole bunch, and this is in the very beginning of the chapter, a whole bunch of different procedures. So again, I want you to go look over that yourself. I'm not going to go into the surgical procedures. It's on page 1362 through 1363. And it gives you the disorder, the type of surgical procedure, and the nursing measures you take for that. Some of the examples I just threw down at the bottom for you just to kind of look over. But it's very specific in your book, and I like the 5th edition for the way they broke that up. Common drugs used for pediatric cardiac patients. You've got a drug guide 41.1 on page 1352 through 1353. And it lays out the medications very nicely for you as well. So you have alprostadil, digoxin, furosemide, heparin, indomethacin, spironolactone, penicillin G, penicillin V, erythromycin, captopril, enalapril, propranolol, atenolol, hydralazine. There's so many different medications. And it's not limited to just those. So you can look in that drug guide. It gives, breaks it down, antibiotics, antihypertensive drugs, other medications. So it's really nice. Plus, it gives you the actions and indications and the nursing implications. So I would behoove you to look at that. Now, nursing care for a child with cardiac disorder. And this just goes back to what I talked about before. We want to improve their oxygenation, promote adequate nutrition, assist the child and family with their coping. If they've had any surgery, provide any postoperative nursing care, prevent infection, and provide child and family education. Now, this is where I was talking earlier about those TET spells or hypercyanotic spells. And so you can see the little blue baby, like really blue. That's a TET spell. They'll have bluish skin when they cry or feed or when they're really, exerting themselves. So how do we relieve that? Well, first of all, you're going to be very calm and comforting when you approach the child. You're not going to show, you may be freaking out inside, but you're not going to show that. Next, you're going to put that child or that infant in a knee chest position. Oftentimes, you can do that knee chest position, and that may be enough to take care of what's needed. But at any rate, the first action outside of being calm and comforting is place the client in a knee chest position. Then you can provide supplemental oxygen if needed. If we need to go any further and we have an order for it, or we can call to get an order for it, we can administer morphine sulfate as ordered. We could start an IV and provide IV fluids, and we could even administer propranolol if it's ordered. But again, a lot of times the child will squat to physically put themselves in knee chest position, or if it's an infant, we're going to put the child in knee chest position. And you'll see it, usually see a difference when we do that. So I liked those two pictures because it kind of gives you an idea of what you'll see with a TET spell or a hypercyanotic spell. So we also, in nursing care, we have to look at the psychosocial interventions with our clients. We need to explain all that's happening with the child and use language that they can understand. And if the child's old enough, we need to get on their level. You may need to use a doll or a picture or something tangible to help show the child what you're talking about. Allow the parents and child to voice their feelings, concerns, and ask any questions. And provide ample time to address those questions and concerns. Encourage the parents and the child as developmentally appropriate to participate in care. That's huge. They're going to be scared, but they're the ones parents are going to be the ones that's with the child or the guardians. So they need to be learning how to do the care. If the child's old enough, the child can learn how to do the care too. And then encourage the child to be as active as appropriate. So we have to work within their restrictions, but we want them to be as active as appropriate within those restrictions. So that's very important. So other things to think about assessment-wise, especially with a child undergoing cardiac surgery, we know about auscultating the heart and the respiratory status. We got to get their temperature and vital signs. We got to get their weight. We need to check their extremities for any peripheral edema, clubbing, and check all their pulses and the upper and lower extremities. Auscultate the heart, noting the rate, rhythm, heart sounds, and if there's any murmurs, clicks, or rubs present. Assess the respiratory status for the respiratory rate, their work of breathing, and breath sounds. Parent teaching for cardiac surgery, we need to go over heart anatomy and its function. What's going to happen before surgery? Location of the child before surgery, during surgery, and after surgery. Appearance of the child after surgery. That's usually a big one. They're not always ready to see their baby like that. Location of the incision and coverage with dressings, post-operative activity level, nutritional restrictions, activity restrictions, medications, all of those things. And that is it. Thank you for hanging out with me. I know that this was tough. I appreciate you very much. Have a great rest of your day.